Can you gently hold it there? Gently, you're on the bowel. Okay, just go in there. So, sorry, just come back. Let me just do this bit, and that's the rest of it. You can see the rest of it's okay now. Then it is just this bit. It should be. Just pass me the whatever you're using before, the diasemi hook. What do you want me to use now?
No, okay, I'm checking
The diasemi hook. Can I have the pedal back, please? This one? No, it's not working. Hold on, yeah, hold on. Okay, I think we have done enough on here for a mesh to sit down. You can see from there, just show them the promontory, from there to there to the promontory, which is there. We have done enough for the mesh to sit down, right? Our next job is to create a plane there, which is obviously the most important part of the operation, right? Let me just, I'm a bit worried about that bowel. Let's go for a second. You can actually leave the bowel there and hold it up there like that for me. Can you do that?
Dr. Sohail?
Yeah. Can you hold that? Yes, I can hear you.
Is a Foley's balloon helpful in any way in this dissection?
You mean putting the Foley's in the rectum?
No, in the bladder. And is that in any way useful?
I think we'll be far out. I don't think that would help us out. Not something that I've tried before, so I can't comment. But it's not working here. Huh? Right. Come on, someone give me the pedal. Right, we are struggling back and forth between various energy devices at the moment, so I'm sorry about that, but we are slowly making progress. Right, what am I using now, guys? Left is
minimum and right is maximum.
Right is maximum. Right, okay, we're going to try with this hook thing that I've not used before as well. So this is minimum? The right is the minimum?
Right is maximum, left is minimum.
Is that the prostate that we can see?
Yes, well, it's the top of the prostate. The prostate should be there.
Yes.
So that's why in a man it's a bit hazardous, because you've not got much room to play. So yes, you're right. So this is the right plane. This is the plane. You can see that. Can you see the Dannon-Valia fascia appearing? That white bit.
Yes.
That's the top bit of Dannon-Valia fascia. Okay, let me just do a quick PR, make sure in the right plane. Can I have some jelly? So I obsess a little bit about this and make sure in the right plane. So I keep doing PRs when, especially in a man. Make sure I'm in the right plane. A bit of jelly on the finger.
Jelly though.
But you can see that I'm pretty certain that's the right plane. Is that uncovered, guys? Just uncover it. Just go in and lift it up. Nice. You should just need to move it. Oh, there's one more. So I'm just trying to do a PR at the moment. Obviously you can't see, and there come my finger. You see how low I already am? It didn't seem that way, but that's just the tip of my finger. And it's barely in the anal canal. So we've already done quite a lot of low dissection. Can you see this?
Yes, we can see that.
So you can see that that's the tip of my finger, and that's hardly the first distal phalanx that's in at the moment. So that's 2.5 centimeters. So we are already pretty low, because that's where you can see the Dannon-Valier fascia, and I won't go any lower than that, because obviously, and even if I was doing, even if this was a woman and I was dissecting between the rectovaginal septum, that's where I should go, because you can see my finger wiggling, and that's the instrument touching my finger. So we are pretty low already, and also we are in the right plane, because that's where my finger is poking. That's where can you see my finger now? That's where my finger is poking. No, thank you. Just give me a tip top, please, or sucker, please. Just open the jaws. So you can see that the shelf was almost at the level of where the intra and extraperitoneal level of the bowel is divided. So, and that's the rectum. That's the top of the, this is actually not even the rectum, this is the top of the anal canal, right there. So if my mesh sit on there, right there, it's going to pick up on his on that prolapse. So I just dissected a little bit more, clean the plane. If I go laterally now, we should be easily be able to, someone asked me about the seminal vesicles. If I go laterally now, we should be easily be able to see the seminal vesicles. Look up there, where is the bugger of a bleeder? There, in there somewhere, isn't it?
There.
Yeah, it's there somewhere. It's okay, it's not, I don't want to burn on there because it's not too far from the rectal wall, if you know what I mean. I don't want to shove an instrument there and try to burn it. I think we'll get it with stitches. We'll get it with stitches. Okay, so that's, can you see the top of the Dannon-Valier fascia there now?
Yes, we can.
That's the top of the Dannon-Valier fascia. So if you're doing a cancer surgery, this is what you should be seeing in your specimen, this bit there. Because, and all your nerves, the nerves of Welch lie between the prostate there and the Dannon-Valier fascia there. So I'm certainly not prepared to go any further down than that. Let me just stitch this little bugger. I don't want to die saving it. Okay, let's. So I'm just going to prepare the mesh now. So could you give me a proline mesh? Just switch the top lights on, please.
Is there any anatomical landmark which would show how far down you're supposed to go? Or it's just
Finger
like,
examination.
it's a finger examination.
And you know, you can see the Dannon-Valier fascia. That's an anatomical landmark. In a woman, it would be a very easy job, because you just lift the vagina, you go between, and you can see all the planes. In a man, it's difficult because. And the second thing is there are two risks here. My colleague just asked me the question: are there any anatomical landmarks? And we are just discussing them. We have seen the Dannon-Valier fascia. We have seen the. We have done the PR examination. So those are the landmarks. And then, you know, for reasons, you can see that the top of the anal canal is there. So what I'm gonna do now, I'm gonna prepare the mesh. Can you guys see the mesh? Can you see the top of the?
No, we can't.
Okay,
see.
I'll show you how I prepare the mesh. Can you see that? Can you give me scissors? Can you see the mesh now?
Yes, but there is too much of light here.
Can you switch the top light off, or just move it away, because I need to see. So just move it away, please. How about now?
Yes, we can see
Okay,
that.
so it's a standard 15 by 15 proline mesh. I don't use a composite mesh because I'm going to stitch the peritoneum on it. If I was going to leave it inside the abdomen, which is what is called the IPOM, the intraperitoneal onlay mesh, I will use a composite mesh, which is an expensive mesh. So I'll just cut to size. Gul, can you hold this? So I just cut to size in a long strip. Can you see me cutting it?
Yes, we can see. Tell us the dimension. 3
Sorry?
by 12?
Beg your pardon?
Tell us the dimension of the mesh that you'll be using.
15 by 15. It's a standard 15 by 15 proline mesh. I'm just cutting it as a long strip.
Yes, how narrow and how long?
Well, it's basically, it's reasonably empirical. I think I normally just, the length varies in everyone, however long it's required to go from the top of the anal canal to the sacral promontory. I trim it inside, and the width is also empirical. It's about I don't know 3 centimeters. You don't need more than that.
Do you stitch it right on the sacral promontory or below it? Because it
No.
said
I tack it right onto the sacral promontory. Okay. Can you just put the camera in, please? So we already PR'd this guy. His prolapse only comes out when he exerts. It's very important when you're doing this operation. If there's a huge big prolapse, it's prolapsing out, make sure you actually put the prolapse back in. I had a colleague who did this operation, stitched the mesh, and while the prolapse was out. So that doesn't go down very well. Tip top, please. Your hands. Another your hands. Why did you take them away? Right. Could you put the operating lights on and move them away, because I'm going to be I would be needing to see my stitching now. Right. Can you open the SE bond, please? SE bond, yeah.
so. You use ethylon, nylon.
SE bond, yeah. I don't think it's nylon. I'm not exactly sure what it is. So that's where the mesh is going to. Now the important thing is that you can see the plane that we have dissected, which is, where is the plane? Oh, sorry, it's fallen down. That's why I can't see the plane. Our colleague has slipped his hand. No, he hasn't actually. Okay, can you hold that there? Sorry, what I was going to say is, come on, there's the peritoneum. This is loose. Can you tighten this? This is not working. See, it doesn't open and close. You had another one, didn't you? The one I was using before. You can give that to me. It's a bit rubbish, but. So let's reassure ourselves. Yeah, that's right. So that's the plane. So I'm going to stitch it right there, but I want to make sure, and I obviously do that routinely in women. It's maybe not very important with him, that I stitch to the body right there. 1, 2, 3. So this bit, the one that I've created as a conical apex, goes sit in between the vagina and the rectum. Are you with me?
Yes.
So that's, I normally do that. So I put my stitches slightly down on those sides. So the conical tip then goes in and buttress the wall between the rectum and the vagina.
How obliquely do you place it? At 45 degrees to the long axis?
How what?
I mean
Obliquely? No, it's just flat out. It's flat right onto the surface of the anal canal.
It is, but it should be placed slightly obliquely so that it comes all the way from the right side of the rectum up to the sacrum.
Yeah. Just point a light on there. This is a double needle. This is the SE bond. So what you need to do is you need to cut the. How long is this SE bond? Sorry, hold that for a second. It's 90 centimeters. So cut that one needle, please. Needle 2. Show me the package, please. Okay, that's fine. Needle holder, please.
Ethibond 2O?
2O, yeah. This one is a 26 millimeter needle.
Right.
So let's see how it works out. I normally use a 24 millimeter needle, but we couldn't find. I'm just getting myself familiarized with the needle holder. seems all right, this needle holder.
I think that's important because the depth of that is going into the rectal wall will obviously differ if the size of the needle is larger.
Outcome.
Just give me a tip tops. Johannes. So we have got one end going in, one end sticking out through the port. Now the angle of the needle has to be right in here because it's a deep hole, so you have to get the needle exactly right as to where you want it. Right, just go in there, please. Just look up there. So our first stitch hopefully is going to go right onto the rectal wall, a deep bite. You can see I've taken a reasonable amount of rectal wall, not too much, not too little. Come out, please. Okay.
How sure you are that you have not penetrated the mucosa?
I cannot be 100%, but even if it is going into the mucosa, it probably won't be the end of the world.
So you do a routine bowel prep before doing this surgery?
Absolutely, absolutely. Now let's see if it's sitting nicely. Go in there for a second. Yeah, so you can see it's, no, I want to see the tip. Come out, Sajida. Right, can you lift your hand down, put your hand down? No, you put your hand down, that's it. So it's sitting where it should be sitting. Come out and touch. Okay, so this is out now. I do extracorporeal knot. Scissors to me, please.
Not pusher.
And a knot pusher. Let's cut that. One knot pushing. We got a knot pushing device, which is now show me the other one. Yeah, this one is the right one. I normally put 4 throws on there.
In a deep cavity like this with a narrow space, extracorporeal is very useful.
Sorry, could you say that again?
In a deep cavity with a narrow space, extracorporeal knots are very useful.
Very useful.
Yes.
Yeah, absolutely. Because if I be throwing knots inside, you guys are going to be here till about midnight. So, scissors, please. Laparoscopic scissors. There are devices now that do stitching inside, so you don't have to do anything at all. You can just incorporate the tissues and just fire it, and it's stitch. Scissors is not, yeah, okay. Let's have a look and see how it's looking. Tip tops, please. Right, just go in, Sajida. Let go, sir. Right. So you can, I want to see the full extent of my dissection. So you can see that at the first stitch I put in, like I've said to you, that the tip, oops, sorry, The tip is sitting right there in between the plane that I dissected. You see that tip there? It's sitting right in between that plane. So that's going to cause extra fibrosis there. Okay, needle please. Sorry, acetone. Cut the needle now and give it to me. Just a thread, because otherwise, if you lock it on the needle holder, it won't go in. Yeah? अगर आप needle पे लगाएंगे ना तो ये अंदर नहीं जाएगी फिर. Just go inside there. Okay. I'll take one right up, or try to take it one right up at the tip.
Please show us the external view.
Yeah, of course. Just hold on for 1 sec. Can you show them the external view, please? So you can see that. Can you see it?
No, there is too much of light actually.
Switch that. Take that away, please. Now.
Yes, better.
So two threads coming out. It's a simple knot. Is Dr. Dawoodi there? Is Dr. Dawoodi there?
Yes, he is here.
Okay. So that's, he was asking me earlier. So it's nothing special to this knot. Just a simple knot. That's it. You hold it there. You just put the knot pusher and you slide it through. Simple as that. Okay, go on, put the camera in please. And here it comes.
No, it's not Reuters. It is simple knot which is pushed.
Beg your pardon?
Is this a Reuters knot?
A Reuters knot.
Yes.
I have no idea what a Reuters knot is.
That's not a Reuters knot.
Yeah, well, my assistant said, Dr. Sajida said that's not a Reuters knot. So obviously it's not a Reuters knot, but I don't know what a Reuters knot is. This is just a simple, I just call it a simple knot. What is a Reuters knot, Dr. Sajida?
That's not required for the appendix.
For the appendix. All right.
Simple knot which has been pushed.
Maybe one more.
Oh yeah, lots more.
Asif?
Okay. I normally put three at the base there, and then I put one further down the body, and then I would put one between the vagina and the rectum, which obviously we won't be doing today. Just pass the needle holder, please. And tip tops, thank you. Okay, so let's go and check. Everything is fine. Sitting there, I didn't pick up too much tissue there, so I'll just try to see if I can pick too much, stick one on there, right on the top of the Denel-Valley fascia. It has pushed, this one has picked up some tissue, but it wasn't as deep as my first one. I like it to be as deep as my first one. All right, you ready?
You purposely make this knot a little loose rather than tight.
Snug. Snug is the word I'll use. I try for it to be snug.
Right. Would you use glue if you had that?
No,
No.
because it's not going to anchor the mesh. We need a proper fixation here. So I personally would use it.